Hello, good afternoon. This is Jamie Stevens. I'm with Centris Health of Kansas City. I want to thank you for joining for this presentation on risk adjustment with primary care focus. To give you a little bit of orientation to what we're going to cover today, the first part of the presentation will be reviewing just a general overview of risk adjustment. Some people on the call may be quite familiar with this, and this may be just a refresher. And for some people, this may be a new experience, and hopefully by the end of it, you'll have a little bit of an appreciation for what risk adjustment is, how it impacts our current payment models. And then the second half of the presentation, we'll look at some specific codes that are highly used in primary care and maybe have a little bit of a misunderstanding about what they are and how they properly reflect what's going on with the patient. And then we'll cover a little bit about documentation and provide some best practices that maybe you might consider implementing at your practice. So if you have any questions, feel free to type them into the question box or into the chat box. You can direct them to me or to the group in general. Or if you raise your hand, if it's a little bit more extensive question, put that in the box or raise your hand and I can unmute your microphone and we can have a discussion. And feel free to do that as we go along throughout this presentation. So with that, we will get started. So this presentation is hosted by Centris Health. For those who are not familiar with Centris Health, I wanted to first give a little bit of background about what Centris is and how your healthcare system is affiliated with Centris. So Centris is what's called a clinically integrated network, which means we have a degree of shared contracting and incentives based on our overall ability to improve the health of patients in our community and do so at the most efficient cost as possible. So ways that we do this are by sharing clinical information, sharing quality information, all in the effort to create a seamless care delivery model across Kansas City. Centris Health is comprised of more than 1,600 physicians and providers throughout the Kansas City region. This represents the employed medical groups of North Kansas City Hospital, Advent Shawnee Mission, and the University of Kansas Health System. There's also many affiliated independent physicians that are part of Centris Health, including those that are part of the Kansas City Metropolitan Physician Association, also known as KCMPA. Currently, Centris Health has major contracts in place with Blue KC, Aetna, and with Medicare through the Medicare Shared Savings ACO program. All right, so I'll begin by giving a general overview of what risk adjustment is, or I may refer to it as RAP, and why it's something that it's important for people to focus on, as well as how current payment models are dependent on our ability to accurately and appropriately reflect the risk-adjusted status of our patients. So Medicare and other payers who use RAF scores, there's various models to determine the anticipated cost of care for beneficiaries based on the documented diagnosis. So there's many thousands of ICD-10 codes that represent diagnosis. Some of those are risk adjusted and others aren't. Other ones that are risk adjusted, if a patient has multiple risk adjusted diagnosis codes, those become cumulative and create an end of the year risk adjusted score, which really reflects how sick that patient is. And from that is calculated how much anticipated cost is expected. So in order to assign the risk adjustment value to the patient, patients have to be evaluated on a calendar year basis. So I know physicians typically aren't used to managing patients on a calendar year. You kind of see them from visit to visit, you manage them, you set goals for those patients, you follow the treatment plan, and time isn't really a relevant thing to that. But in terms of risk adjustment, it's good to keep in mind that in January, all the risk adjusted codes and all the diagnosis codes that you've attributed to that patient start over again. And every year we have to report these codes to the payer so that they can evaluate and determine the acuity of that patient. So in order to do that, the patients need to be seen at a face-to-face visit with any physician. So it could be a specialist, it could be a primary care provider, but it has to be during a face-to-face encounter. Or today, telemedicine would be included with that. I know that there's been a big shift from traditional visits to telemedicine visit. So it's certainly appropriate to code and assign those risk adjusted values when it's seen in a telemedicine visit as well. in order to support the diagnosis that we submit, the provider has to assess, treat, and document the risk-adjusted diagnosis in the medical record on an annual basis. What happens from there is the billing department has a responsibility of evaluating the claim, assigning those risk-adjusted diagnosis, and submit those to the payer on the claim. So oftentimes we have very complex patients that have multiple problems, and physicians are dealing with many different diagnoses at each visit. So it really becomes a challenge at times to determine what are the most high priority risk-adjusted codes that were addressed during the visit. There's a limited number of codes that can get on the claim. So really having some prioritization of, hey, this is a risk-adjusted code. It was clearly addressed during the office visit. Let's make sure that those diagnosis codes get submitted on the claim and passed along to the payer. And not everything has to be evaluated on the first visit of each year. It may be something that if the patient routinely comes in 4 or 5 times a year, it can be progressive, or also at an annual wellness visit for a Medicare patient or a complete physical for a commercial patient. Those are good opportunities to have a comprehensive review of what's going on. Make sure that all those risk-adjusted diagnoses are included on the assessment, and the coder can make sure that they're submitting the most appropriate ones that they can. The other challenge is if a patient doesn't come into the office at all. So if a patient only comes in for an acute visit, but they've got all other kinds of problems that they don't routinely schedule for, sometimes it may be taking an acute visit and turning it into a more comprehensive visit, especially now if your practice has slowed down a little bit. Hopefully things are picking back up again, but it may be an opportunity to spend a little bit more time maybe turning those visits into a more comprehensive type visit, even if the patient's there for an acute visit. So this model really places a higher importance on documenting and coding all the conditions that the patient presents with. And then these codes are then used to determine what the expected cost of care for each patient is. So generally, the higher the risk-adjusted score on the patient, the greater the anticipated cost of care. And that creates opportunities where if we're in a shared savings type arrangement, if we're working with a practical anticipated cost of care and we come in and deliver efficient care that's good quality below what is expected, that gap in between actual costs and anticipated costs is the opportunity where shared savings can be activated. So this next slide is going to show a couple different scenarios on how coding variations impact our ability to influence a patient's risk score. The 3 boxes on this slide show the same patient, but it was coded in 3 different ways throughout the year. So this patient is a 76-year-old female, and in a model like the Medicare model, each patient is assigned a demographic risk score, which is attributed by the age of the patient and the gender of the patient. So in this case, it's a 76-year-old female, and that provides a patient with a risk-adjusted score of a 0.452, and that's the same across each scenario. You can see the top line there. And what we know about this patient is in the past, they've been diagnosed with major depressive disorder, cardiomyopathy, COPD, morbid obesity, and that if all these codes were coded, they'd accumulate into an average risk score. So the box on the right shows if none of these codes were captured. So maybe this patient wasn't seen during the calendar year, or they were just seen for an acute visit and weren't really coming into the office. You can see that none of the diagnosis codes were captured, and at the end of the year, this patient's total risk-adjusted score is the same as their demographic. It's a 0.452. So based on that, the patient would have an expected cost of care of $316. And this is making a couple of assumptions. This is assuming that the average health patient is a 1.0 risk-adjusted score. Medicare makes that calibration each year. And this also assumes that an average health patient would cost $700 a year. So if you look at the problems that this patient has, it's probably unlikely that we're able to manage this within $316 a month. It's less than half of what an average health patient, and this is certainly not a patient with average health. So the box in the middle, the yellow box, shows if some of the diagnosis codes were selected. So this patient came in and the provider coded F32.9, which is major depressive disorder, single episode, unspecified. So the depression code was captured, but this patient wasn't coded using a specific enough code that would give risk-adjusted credit for. So even though it was captured, it was a zero risk-adjusted value. Cardiomyopathy unspecified was captured. Even though this is unspecified, it's still a risk-adjusted code, so a 0.337 is added. The COPD was not coded, but the morbid obesity due to excess calories, which is E66 6.01, was coded, which adds a 0.262. So after these select diagnoses were captured, this patient's cumulative risk-adjusted score climbed up to slightly above average at a 1.051, increasing the anticipated cost of care for up to $736. So it's not totally reflective of what's going on, but it certainly shows that this patient's at least slightly worse than average health than the average person. So the green box shows what happens when all of the diagnoses were selected. So the major depressive order was again coded, but it was coded with the severity of in partial remission. So that added a 0.353. Cardiomyopathy was captured again. COPD was captured this time, which added a 0.282. The morbid obesity was added. And then there was an additional code that since this patient has cardiomyopathy and COPD, an additional risk-adjusted weight was added to take into account the complexity of managing patients with these comorbid conditions. So this patient's end of the year total RAF score was a 1.876, which is significantly higher than average, and increased the budget to $1,313 per year. So when you look at the different coding practices and how it impacts the anticipated cost of care, the monthly budget was increased by almost $1,000 a month from the red to the green box, which is a change from going from about managing a patient at an annual cost of about $3,800 to almost $16,000 a year. So it's much more realistic that this patient is expected to take at least that. That's what the anticipated cost of care is. So if we're able to get up to that and provide care for, and that includes the cost for outpatient services, inpatient services, if the patient goes to the emergency room or has any lab or imaging done, it's much more realistic that we can manage within that budget than at something less than $4,000. So on the previous slide, I mentioned that there's some diagnosis categories that when found together, there's additional award of risk adjustment weight. So this table shows those most common groupings of what we would see in primary care for added risk adjusted weight when found together in the same patient. So for example, if a patient has an immune disorder and cancer, an additional 0.893 is added for having those comorbid conditions together at once, just because that's such a complex medical situation to manage. Congestive heart failure is the most common theme that runs along here. So if a patient has congestive heart failure with either diabetes, COPD, or arrhythmia, they're added an additional anywhere from 0.182 to 0.336 in additional risk-adjusted weight. Same with COPD, 0.336 is added if they have cardiorespiratory failure. So nothing special has to happen. So if you see patients and you just code these diagnoses throughout the year, this cumulative additional weight gets added behind the scenes. There's nothing you have to do to link these together. You don't have to do anything special to receive this additional risk-adjusted weight on the patients that you're managing. Again, if anybody has questions, feel free to type them in and I'm happy to address them as we go through. All right, so next we're going to shift into slides that look at the various diagnoses that we see. And this information was gleaned from going through claims data. So all those contracts that I mentioned with Medicare, Blue Cross, and Aetna, on a monthly basis, we receive the most up-to-date claims files from those organizations on the patients that we're seeing. So when you submit a claim, it goes to the payer turns around and sends that back to Centris. So we can do some analytics on it and make some assumptions or look for trends that we see. So a lot of this information was kind of gleaned from going through that data, understanding comparisons of what we know about the population, and then meeting with several primary care providers, specialists within your systems to have them look at the data, have them help us determine what maybe doesn't look right and what some opportunities are. And that's where this kind of came from. So this first slide is going to have to do with diabetes. Actually, the next two slides are going to discuss diabetes. Diabetes is first because it's the most commonly captured risk adjustment diagnosis among primary care providers within Centris. Risk-adjusted weights are different for patients who have chronic complications as opposed to those without. So if a patient has type 1 or type 2 diabetes and they're well controlled, they don't have any complications, the risk-adjusted weight assigned to that patient is a 0.106. And what we see when we look at the data is we see a lot of patients that are coded as diabetic patients without complications. If the complication is taken into consideration, the risk-adjusted weight goes from a 1.06 up to a 0.307. So it's almost a 3-time increase of what we see on the risk-adjusted weight of these patients. And we'll go through and look at different profiles of providers and see what their code use are. And we'll oftentimes see some groupings of patients that maybe 90% of the time patients with diabetes are coded as without complications. And very rarely do we see complications, whereas in other cases we see doctors who are really specific about coding complications, and they have many patients with complications with multiple other conditions coded, which really supports that. So there is no right number of how many should and how many shouldn't have complications, but it's interesting to look at across the peer groups of providers within the same system or the same clinic or across all of Centris to see what code uses are. And there's probably some opportunities out there around coding complications. So this next slide just has the most common diabetes with complication codes. These are all risk adjusted at a 0.307. And as I mentioned in that risk adjustment is cumulative in nature. If you have 3 of these complications from the top part of this table, so say the patient has hypoglycemia, nephropathy, and CKD, you only receive that, or the patient only has an increase of a 0.307 one time on that patient. You can't increase it multiple times with codes from the same category. But if this was a patient with also who had CKD and you stage the CKD at a point or at a stage 4, you receive like an additional 0.1 or so risk-adjusted score because of that comorbid condition. So as specific as you can with coding the complication, and then coding the specifics around that problem when that's appropriate really does help increase the support for that code and increase the risk-adjusted value. All right, next we're going to look at major depressive disorder. I touched on this a little bit before. This is another area where we see sometimes maybe a code that doesn't have the specificity required to achieve risk adjustment may be found. So we found a frequent coding for major depressive disorder is using the F32.9, which is major depressive disorder, single episode unspecified. And this code doesn't provide any kind of risk-adjusted weight at all. I showed that on, I think, the yellow scenario of this slide that was doing a side-by-side comparison. So depression needs to distinguish between the whether it's a single episode or recurrent, and then the severity of the depression. So if you just code a major depressive disorder, single episode mild, as opposed to non-specific, it'll give that risk-adjusted weight. Normally, when we see people coding risk adjustment codes on major depressive disorder, it's either recurrent with moderate or recurrent in remission. So even if the patient is managed either through medication or by going through therapy or is in total remission and just self-managing that, it's appropriate to use that the patient is in remission. And you can still achieve risk adjustment credit for that. So the next slide is vascular disease. So this could be another commonly overlooked code for vascular disease. We see quite a bit of variation among the use of these codes by providers, specifically around atherosclerosis of the aorta, which is a commonly found diagnosis in this community. We know a lot of people have that, but we see some variations across provider groups on how often they code this. So this is something that carries an additional weight of a 0.31. So it's about the same severity as a patient who is a diabetic patient with complications. So I-70.0, atherosclerosis of the aorta, this is something that's commonly called out by radiologists, or if you're doing your own x-rays, you can see it on an x-ray or lumbar, chest or lumbar x-ray, CT scans. If it indicates some degree of atherosclerosis of the aorta, it's fair to include that on the problem list. It's important to denote why that's relevant to the clinical condition that you're seeing, if you took any action or had a treatment plan for that. But by indicating it, putting it on the problem list so that it's there for future use, even if it isn't the primary focus of your visit, it's important to do that and provides a significant amount of risk adjustment. All right, next is pneumonia, which is another one that kind of falls into that grouping. Oftentimes we see that an unspecified pneumonia code is used, especially at a primary care level. So J18.9, pneumonia unspecified, is not associated with the risk adjustment value. But if you're able to specify the location and the type of organism or bacteria, then it carries a risk adjusted weight of a 0.313. So you'll notice that at the bottom of the table, even if you use this, the most common appropriate code that we see being used, and I've done this presentation with pulmonologists a couple times over the last couple days, and they've called this out as well, that at the time they never really know what the organism is. So low burn pneumonia, unspecified organism, J18.1 is risk adjusted. So even though you don't have the full idea of what the organism is, this is still risk adjusted. And with reviewing this, this is probably the most appropriate code that would be used in place of the J18.9. And I know that some EHRs have coding issues that go along with it. Like if you search pneumonia, there's going to be a ton of different pneumonias. And sometimes maybe this one is the first one that's on the list, or I've seen EHRs where the name gets cut off and you can't even tell what the full pneumonia is, what the code is. So it's difficult to go in and click through that. But if you could become familiar with just a few of these codes, I think even if we were able to appropriately and accurately capture and code and address the pneumonia, the depression codes, and arteriosclerosis of the aorta, that would have a significant impact on each individual provider's risk-adjusted factor, as well as the collective risk-adjusted, average risk-adjusted score of the patients within your system's population. So I know that there's a million codes out there that we could focus on, but I find that by focusing on 4 or 5 and becoming really proficient at identifying opportunities for that, putting them in is going to go a long ways in increasing risk adjustment. So heart arrhythmias is a common thing that we see. Cardiologists code these all day long when we see that. I've done this with cardiologists, and it's really not an issue. Something I've encouraged them to do is, if they see patients and they're managing them, and I've talked with all the specialists that have joined these webinars, is really be as specific as you can with your diagnosis on your notes when you send it back. If it's a specialist that shares a common medical record, so if you're at KU and the specialists use Epic and so do the primary care providers, updating the problem list. If there's codes that are non-specific that really don't reflect what's going on with those, replace them with ones that really are, so that when it comes back to the primary care provider, that code's available. You may be managing that condition, even if it's managed by the cardiologist or by a specialist, you're still factoring that into your medical decision making. So it's fair to bring that in and address it, and just indicate that it's stable or being managed by somebody else, or associate a medication with it, so that the credit can be provided, it's well supported in documentation, and that it's entered into your medical decision making. So even if it's not the primary focus of what you're doing, it's still appropriate to manage it at that level. All right, so here's one that we don't see a lot of use of, so I thought it'd be a good idea to call this out, is cardiorespiratory failure and shock. So many patients with severe longstanding COPD also have chronic respiratory failure. So typically patients with chronic respiratory failure require some kind of home oxygen use. So the diagnosis could be considered if you have a patient on home oxygen. So if you see a patient come into the clinic and is on oxygen, this is a code that you may want to consider. Oftentimes what we see being used is a Z99.82, which is dependence on supplemental oxygen. And this is a generic non-risk adjusted code. It probably gets the claims paid fine, and it probably gets the home health orders or the DME orders paid to cover the oxygen use. But if you're able to use the J96 codes that are shown at the bottom to accurately reflect what's going on with the patient, then it adds a risk adjusted weight of a 0.282. Which just gives additional credit for the complexity of managing this patient. So acute and chronic respiratory failure with hypoxia, or chronic respiratory failure with hypoxia, would probably be the most common codes that you could use in those circumstances. So dementia is a complex issue that we see in the practice. And up until 2020, dementia for some reason wasn't risk adjusted. There's a handful of codes that you would think would be, like Parkinson and previously dementia. That's highly complex. There's a lot of things going on with these patients, but no risk adjusted score was assigned to them. So beginning in 2020, dementia received risk adjustment credit, and it's now risk adjusted at a rate of a 0.346. And it's the same whether a patient has dementia with or without behavioral disturbances. Dementia has been important in the past for programs like the CPC Plus program. If your clinic participates in that, additional funds were made available for managing those patients, as well as in the ACO program. Patients with dementia and ESRD are put in its own separate categories because there's such high costs associated with these patients, and they're much more complex that it's not fair to put them in with the rest of your population. So common diagnosis that we see coding in association with dementia are also not risk adjustment. So R41.82, altered mental status unspecified, we saw that quite a bit with these patients, as well as hallucinations unspecified, R44.3. So codes that you might want to consider with this patient: if they have depression, it's certainly fair to code depression, or delusional disorders or unspecified mood disorders. They might be a little bit more specific, especially on major depression disorder. And coding those together, that would increase the risk adjusted weight that goes along with this. So here's one that you've probably heard from your coders on or had some discussion about: morbid obesity. I bring this up for a couple different reasons. One is that there's two different ways to categorize or diagnose a patient with morbid obesity. The first one is the most common, which is any patient with a BMI equal to or greater than 40. But the other way that you can qualify this patient as being morbidly obese is if they have a BMI equal to or greater than 35 with some other comorbidity that's influenced by their obesity. So if a patient has diabetes or hypertension or any chronic disease like that, that could be potentially exacerbated by their high BMI, you're able to code that patient as being morbidly obese because they have this other comorbid condition. So there's two different ways to code morbid obesity. The first one is E66.01, which is morbid severe obesity due to excess calories. If you're qualifying the patient for morbid obesity because their BMI is between 35 and 40, I'd encourage you to use this code and code along with it the diabetes or whatever it is. Typically that's done when you're doing a follow-up visit for those patients anyway. I think people do a good job with that. I think the call out that I wanted to make though is that if a patient has a BMI of 35 or greater, it's an opportunity to use that. Depending on your organization and how your coding practices are, these Z codes are used to stage the BMI. So in some organizations, the provider may pick the Z code out and code the BMI, or in other areas, it could be the coding department just looks to see what the BMI is on the patient and adds that. In the last couple of years, Blue Cross has really pressed us to code BMI by value so that they understand what the patient's BMI is. I think it was one of the quality measures for the PCMH program recently. So it's really important to focus on that. That's probably already being done at your organization, but you may want to ask the question, what's the most efficient way to get that BMI credited and added, especially if a patient is between 35 and 40. So on the other side of obesity, protein calorie malnutrition is prevalent with patients with cancer, CKD, maybe liver disease or substance use. And the clinical criteria to make this diagnosis is if patients have a BMI that's less than 19, or they have a 10% weight loss in the previous 6 months, or they have an albumin that's less than 3.5, or they have evidence of muscle wasting or fat loss. So this adds a pretty significant risk adjusted weight of a 0.493. I can't say what the prevalence of this is. I get the sense just looking at from some comparative data from Medicare and other programs that we're probably undercoding this. And I understand that if a patient has cancer or they have a severe other major problem, that this may not be the top of mind to code, but this puts somebody in a much higher risk category and a pretty high risk adjusted factor of 0.493 reflects that. So if somebody meets this criteria, it may come to mind to code this. This may be something that you'll want to provide to your medical assistants or nurses that check people in, that if they have a BMI with this, they may want to flag this as a potential diagnosis. All right, so this next table here shows a little bit about some documentation examples that support risk adjustment. So when we're submitting risk adjusted codes, it's really important that the documentation that's in the chart matches up with what we're reporting as a diagnosis code. The primary intention of this presentation isn't to provide direction on how you should code or how you should document. Each of your systems and organizations likely, and I'm certain, have a robust system to direct how providers need to document in their notes, what document or what types of documentation are required to support the claims that are being submitted, and then if codes look off to the coder, what's the communication like back and forth between the provider to reconcile that. So that's not my domain to get into, but I did want to just give some general standings and some overview of what important elements are, if that's helpful. So when you're looking at risk adjustment, oftentimes Medicare Advantage audits and things like that will use the acronym of MEET to see if the code met the documentation support needed to be associated with claim. So MEET stands for monitor, evaluate, assess, and treat. So having some element of this acronym in your chart helps support the code. So for monitor, you may state whether the patient's condition is stable or out of control or improving. If the patient's testing at home, what they're doing to self-manage their diagnosis. You could use evaluate by citing how the blood sugars are running, referencing any kind of lab results that the patient may have had recently, any change in the status. You could assess by providing counseling or reviewing records or other documents, and you treat by, the most common one is prescribing medications or making referrals or consults to other providers, and basically anything that comes into your plan of care for managing these patients. So a couple of things that we've seen from different practices. A lot of people have different initiatives in place to accurately capture the risk adjustment factor. We have a risk adjustment committee as part of Centris that has each of your systems represented on there. Some of the things that we've talked about in that committee and some best practices that we've observed from higher performing groups really start with the problem list. Having a good up-to-date problem list with the most specific codes available is really one of the best ways to manage this. So if you have a problem list that has non-chronic issues on it, things that have been resolved long ago, or duplicate diagnosis that kind of mean the same thing, it's best to reconcile those. Look to see if there's an opportunity that some of this stuff is risk adjusted, get the most accurate code on there and maintain that. And that goes for specialists all the way down to the primary care providers. This oftentimes seems like a primary care initiative that we have to get these risk adjustment codes in and we have to manage it, but certainly specialists can participate in this as well and really help us out by being accurate with their coding. This can be helped by the staff. Like I mentioned, if the patients come in with certain conditions that are probable, they can help add those into the assessment, be reviewed by the provider. As consult notes get sent back from specialists, somebody can take that code that the specialists use to diagnose the patient and make sure that that finds its way on the problem list. Some groups do pre-charter audits, so that could be billing staff going through and figuring out which codes haven't been captured yet for the calendar year and flagging them. You can review the previous history. I often find that a good way to catch risk adjustment codes is by doing a really good job with quality as well. So everybody's EHRs have flags in them, or you have reports that you look at. If a patient's past due for an A1C, you're addressing their diabetes, you're reviewing their past labs, you're ordering a new one, and depending on the outcome of that, they may have a new complication. Doing foot exams, ordering lab, doing a comprehensive workup on patients with COPD. As they come in and we fill these quality gaps, it's a really good way to also make sure that we're doing a good job on risk adjustment. They kind of go along together. And then the other one is really looking at what's your relationship with your coding team? We see the highest performing groups have good relationships with their coding department, and maybe quarterly or three times a year, they would meet together with the provider, the person who does their coding predominantly, and including the nurses in that, since they're often involved in working up those patients, reviewing the patient's charts, seeing what's going on. So the coders have a lot of information about what your coding trends are, maybe areas where you could do a little bit more to support your diagnosis, or if you're way over documenting what's needed for that, they probably have a pretty good sense of that. They're not going to complain about over documentation, but they may have issue with under documentation. So finding the right balance of how much documentation is needed is always a challenge. I get that we don't want to overburden doctors with a lot of additional work related to coding and administrative services. It just takes a lot of time, and it's not really their central function. They need to be in front of patients, taking care of them, and making decisions about complex medical problems. So honing it down to what's needed, having a small subset of codes that we focus on to improve. You know, maybe you want to focus on diabetes, atherosclerosis of the aorta, and capturing non-specific depression codes. That's probably enough for a quarter, and see what you can do, and then as you get better, add on a couple. Whereas there's probably providers on this call who know all this stuff, and they're maybe capturing more advanced nuanced codes. But anything we can do to make incremental improvements in capturing the accuracy goes a long ways for that. So Centris Health has access to a lot of this data, and we want to be available to support physicians and practices however we can. So this, what you see on the screen, is an example of a report from our claims data. So we're able to look at different providers' code usage and do a comparison that includes a count of how many times a code was used on a population, as well as an adjusted rate per 10,000. So we could look at an adjusted rate per 10,000 for one provider, compare them to doctors within their own practice or within their system, or against all Centris providers across the city. And like I said before, there isn't a right number of diabetic or hypertensive heart failure patients that we should have. But you can see where maybe your coding is in line with people that you think have similar populations, or maybe areas where they outperform what you are, or vice versa, and have some shared discussion about how do people capture diagnosis, how do people account for the acuity of their patients, and what are some areas that we can focus on going forward. So things like these reports, these webinars, the goal of these are to provide some information to help the providers make some decisions about what's appropriate for their practice. So that really brings us to the end. In conclusion, risk adjustment is really an important factor in the way that we get paid. We're increasingly moving away from fee-for-service more towards these quality and value-based payment models. So if we're not doing a lot of work on risk adjustment, we're really going to make a difficult situation for us to be successful in. I encourage you to become familiar with the codes that are specific to your practice and ones that you may want to work on improving. Keep in mind that coding in this model needs to happen on a calendar year, so recapturing those codes year after year would be helpful. Managing the problem list is a good pathway to being successful with risk adjustment coding. Any kind of reports from Centris or from payers oftentimes, especially with Medicare Advantage, or internal reports that are generated within your system. Use those and have your staff participate in using those to capture codes on patients that are coming in. And just one more time, emphasizing the importance of having appropriate documentation in place to really support the codes that you have. So with that, that concludes the presentation. If there's questions, I'm happy to answer those. You can type them in, or if you raise your hand, I can unmute you and we can have a discussion. Okay, I'm not seeing any questions come through. As you get off the call, you'll be prompted to take a brief survey. I think it's 5 questions and shouldn't take more than 15 or 20 seconds to answer. If you wouldn't mind doing that on the way out the door, I'd appreciate it. If you have any questions related to risk adjustment, feel free to contact me or the contact person within your system that's responsible for that. That's probably your best place to start, and we're happy to provide any support that we can. Great, thank you for your time this afternoon. I hope you have a good rest of your day. Oh, there was a question about the PowerPoint. Yes, we will have a copy of the PowerPoint. We'll send it out at the end of the conclusion. We have a couple more of these to go. And then sometime next week, a video of one of these presentations on the topic will be made available. So if people who weren't able to join one of the live presentations, they'll be directed to a YouTube site or something like that they can view the presentation on their own time. I'd encourage to pass it along to your colleagues that weren't able to make it. And if there's coders that aren't able to make it or nurses that you think would benefit, that would be great. All right, I don't see any other questions. I want to thank you for your time. I hope everybody has a great afternoon. Thank you.